Hey folks, welcome back to Discussions with Dr. G. Dr. G here, pharmacology nerd, cat servant, and the person who still mispronounces most monoclonal antibody names. So, let's get to it. Before we talk about blood thinners and all the ways nurses wind up playing detective with bruises and bleeds, we really got to nail down how clotting is supposed to work in the first place, and well, how it sometimes spectacularly doesn't. I always tell my students, your body is basically running a high-stakes balancing act between clotting just enough to plug leaks and not so much that you turn into a walking traffic jam. When you're injured, let's just say you walked into a table corner at 2 a.m. while you were looking for snacks. Your blood jumps into action, forms a plug with platelets and a bunch of proteins joining forces in what we call the coagulation cascade. It's this beautiful, organized chaos where blood clots at the spot of the injury. And then afterwards, your body's supposed to sweep up the mess so you don't get stuck with random clot souvenirs. That's hemostasis in a nutshell. Now, sometimes the system gets a little, over-enthusiastic, or it slacks off completely. That's when we step into the wild world of hypercoagulation and hypocoagulation. Hypercoagulation means your blood is so eager to clot, it starts blocking up where it really shouldn't. Think about folks with atrial fibrillation, prosthetic heart valves, or a history of deep vein thrombosis, DVT, pulmonary embolism, PE, myocardial infarction, MI, or stroke. You know, the greatest hits of blood clots. Stasis of the blood, hypercoagulability, and endothelial injury. That's Virchow's triad for you, and you'll want to remember that for every exam. Conversely, hypocoagulation is where the whole system underperforms and you end up with way too much bleeding. Classic examples are hemophilia, heparin-induced thrombocytopenia or HIT, and good old liver disease. Oh, and clinical manifestations? Totally different. DVTs show up as this hot, swollen, angry limb like it's mad that you skipped leg day. PEs? Chest pain, shortness of breath, maybe a little fainting just to spice up your day. And if you're leaking instead of clotting, you get those people who bruise at the sight of a cotton ball or have nosebleeds that just won't quit. Speaking of that, did I ever tell you about the patient who thought anticoagulants sounded like something from a sci-fi movie? Well, he got a prescription for anticoagulants and then a tiny nosebleed turned into a week-long episode of paper towels and panic calls. Honestly, it's all fun and games until you realize your blood is an overachiever, or worse, it's on strike. So let's jump off that science fiction train and talk about the real magic potions. Blood thinners. You've got the rogues gallery here. Warfarin is the OG vitamin K antagonist. The heparins, both unfractionated and low molecular weight. That's UFH and your friend enoxaparin. Then your newer kids on the block, the direct oral anticoagulants or DOACs like apixaban, rivaroxaban, and dabigatran. And everyone's favorite couple, aspirin and clopidogrel, with glycoprotein inhibitors popping in for cameos. So let's start with warfarin. That's the big deal. I mean, warfarin is practically the definition of high alert. It mucks with your vitamin K dependent clotting factors. And if you miss a dose or wing it because you got a vibe, trust me, that's a recipe for disaster. Monitoring? You cannot escape the International Normalized Ratio or INR. You want those magical numbers between 2 and 3 or a little higher for folks with prosthetic valves. Miss that target and you either get clots running amok or spontaneous, impressive bruises. Oh, and don't even get me started on how eating kale, like it's a personality trait, is absolutely going to wreck your INR. Pro tip, steady vitamin K intake. If you change your diet, you check the INR. For reversal, of course, it's going to be vitamin K1 or fresh frozen plasma if things are really going south. Heparin comes next. Old, reliable for acute stuff. You run it in an IV or give it sub-Q, it acts fast, but you've got to monitor APTT or activated partial thromboplastin time. And that's going to be 1.5 to 2 times their baseline, which is about 25 to 35 seconds. Plus, check those platelets because of HIT, heparin-induced thrombocytopenia. Talk about irony, right? Thrombocytopenia is a low platelet count below 150,000 per microliter of blood. Keep in mind that the reference range for platelets is 150,000 to 400,000 per microliter. Okay, more heparin and suddenly not enough platelets to go around, but more clots appearing everywhere. Bleeding is always a risk, so keep protamine sulfate on standby for reversal. For the people who hate frequent blood work, direct oral anticoagulants or DOACs like apaxaban or rivaroxaban are all over the commercials now. They go straight for factor XA. Predictable dosing, don't need constant INR monitoring, but they do have their own special brand of boxed warnings. Abruptly stop these, your patient gets a clot. You'll get a panicked phone call. So yeah, no winging it. Reversal is andexanet alpha, just in case. Dabigatran is a direct thrombin inhibitor, and its reversal agent is unpronounceable. Let's try it. Idarucizumab. Try saying that 5 times fast. Then there's the antiplatelet team. Aspirin. Classic. Great for MI and stroke prevention, but don't give it to kids. Hello, Ray syndrome. Or folks with GI ulcers. Clopidogrel. Need to stop this at least 5 days before surgery, and definitely avoid combination drugs like omeprazole. Otherwise, you won't get any benefits. And glycoprotein inhibitors, those are your heavy hitters for acute coronary syndrome or during PCI, also known as a percutaneous coronary intervention. But you've got to watch out for bleeding and thrombocytopenia. All of this is to say, if you want to get creative with mixing and matching or suddenly holding these meds, you are asking for trouble. I've seen folks stop warfarin on a whim and end up with new clots. It's not like skipping your vitamins. You're going to notice, I promise. So with all these high stakes meds, where does that leave nurses? Well, squarely in the center of chaos, of course. Safety's the name of the game. Start with bleeding precautions. Soft toothbrush, electric razors, skip the bungee jumping on your days off. You got to avoid NSAIDs and aspirin unless the doc tells you otherwise. And this cannot be stressed enough. Report any falls, head injuries, blood in the urine or stool, and even a weird headache that won't quit. Patient education is where you are going to shine. You remind them that if they're on warfarin, their love for spinach needs to become a steady, monogamous relationship. For DOACs, emphasize how they need to take it exactly as prescribed because missing a dose is not a catch you next time situation. For all these meds, monitor labs. Your INR, your APTT, your CBC, your platelets, even renal and hepatic function. You name it. And let's talk about emergencies for a sec. You've got to know the reversal agents, know the boxed warnings, and watch for those oh crap scenarios. A sudden drop in platelets, lots of bruising, bleeding that doesn't stop, or your patient suddenly looks pale and is blaming a lack of sleep, when it's really a hemoglobin of 7 with a normal range of between 12 and 17.5. It's dependent on your born gender, by the way. My favorite teaching moment, walking a class through a patient on both aspirin and warfarin, and they roll in with fresh bruises and everyone's ready to sound the emergency alarm. Someone always asks, is it really that big of a deal if they use a soft toothbrush? And then the light bulb moment hits. A tiny scrape in the mouth can be all it takes for major bleeding if your clotting's off. I get the collective student gasp every time. It's honestly the highlight of my teaching week. Bottom line, you're the early warning system for complications and the educator who makes or breaks safe administration. Monitor, double check, and teach. All right, that wraps us up for today. Next time we'll dig even deeper into more cardiovascular meds. So stay safe, monitor those labs, and I'll see you next time.